Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Guru Murthy, who's assistant professor in medical oncology, hematology at the Medical College of Wisconsin. And he's going to talk to us about an entity that is getting increasing traction and new therapies, an exciting area of research and treatment, Blastic plasmacytoid dendritic cell neoplasms. Pretty much of a tongue twister, even for medically qualified people. So, welcome, Dr. Gurumurthy.
Thank you very much, Dr. Vij, and thank you very much for giving me this opportunity. Really excited to be doing this for the My Cancer Haven platform. And as you suggested, it's a rare disease and it's a very difficult term for many of us to even get together because some of these nomenclatures have been named only in the last few years. We call it in short as BPDCN, and the longer version is Blastic Plasmacytoid Dendritic Cell Neoplasm. And in the next few minutes, we'll be reviewing more in detail about what this condition is and how it is diagnosed and how it is managed. So, just as a brief background, this is it's an aggressive hematological cancer, and it originates from group of cells that are called plasmacytoid dendritic cells that are precursor cells in the bone marrow. It is characterized by malignant expansion of these cells, and those malignant cells do tend to have infiltration or tendency to accumulate in multiple different tissues. So it could be in the bone marrow, in the peripheral blood. It could manifest in the form of skin lesions where the cancer cells are deposited. And it could also have additional organ involvement depending upon individual patient presentation. It is largely a disease of adults, and majority of the times we see this happen in older adults, usually over the age of 60, but it can happen at any age technically. And it is a challenging diagnosis because not many are aware of this condition to begin with. And it does definitely need a high index of suspicion and a qualified pathologist to actually have a suspicion and confirm this diagnosis, because this is one of the diagnoses where if you don't look for it, you might end up missing it or misdiagnosing as something else.
So obviously, you hinted that this is an entity that has recently, been uh, fine-tuned in terms of how we diagnose it. So could you give us a little bit of a historical perspective? Obviously, this entity didn't spring up from nowhere, so it has been in existence. It's just that we recognize it as a discrete entity more and more recently. So could you provide us some perspective as how this has evolved?
Absolutely. So this has evolved over the last few decades. Originally, it was identified to be a unique condition back in the 1990s. And then the names that had been given to this condition had been very, very different. All of them were pertaining to the blastic morphology that has been seen in this condition. So it used to be called as blastic NK cell lymphoma. And then based upon the antigens that are commonly expressed like CD4 and CD56, it's used to be called as CD4 positive, CD56 positive hematodermic tumor. And then it was recognized as a unique entity by the World Health Organization classification sometime around 2008. And then in the 2016 version of the WHO classification, it became a disorder that was classified under the myeloid neoplasms and acute leukemia. And then subsequently, it has been included as a myeloid neoplasm and an acute leukemia with a different category that is being mentioned in the or called out in the subsequent WHO classifications. And with more research and with more information that we are learning, it is likely that this would become a more and more sophisticated entity moving forward.
So, as far as the entity goes, how common is it?
It's a very rare condition. Not that many are being diagnosed by this condition. As with this condition, so on an average, less than 1,000 patients all throughout the world. Even if we look into the US, we published on this data a few years ago. The number of patients who are being diagnosed are relatively small in number, and they don't tend to happen as common as, let's say, for example, how often acute myeloid leukemia gets diagnosed. Even at centers that see high volume of patients, maybe these are like 2 or 3 patients in a year for even a high volume center. So I think trying to keep that in mind is going to be important because this is a rare diagnosis. And then additionally, we talked about a few aspects like at what age group it happens. Like say, for example, mostly the older adults, 60 to 70 years are going to be the common presentation. And there is a preponderance for males to be affected more commonly than females for reasons that we are not clearly aware of at this point of time. And again, this is also a condition where we don't have a very good understanding of what are all the risk factors that predispose to this condition. Majority of the times when we see BPDCN, it tends to be one of the first cancers that get diagnosed in patients. There are some situations where we do see some overlap with other cancerous conditions. For example, like we see an overlap between CMML and BPDCN in some situations. But again, these are not causally related. They are associated is what I'm understanding at this time.
So, in terms of the entity, I think you hinted a little bit about its clinical characteristics, but can you give us a little grounding on the pathophysiology of this disease?
Yeah, so as I originally mentioned, this the cell of origin is actually the plasmacytoid dendritic cells, and those are important cells that play a role in the normal immune system in healthy normal individuals. When there is a malignant proliferation or aggressive proliferation of these types of cell, those cells tend to express certain markers that are relatively very classical of BPDCN. For example, like CD4, CD123. CD56 and TCL1. These are common markers that are usually represented in malignant cells of BPDCN. So these are some of the common markers that the pathologists use to make this diagnosis. And then subsequently, other additional markers may also be expressed, but these are some common ones that we rely upon. There are certain gene expression profile signatures that are unique to BPDCN as compared to myeloid and other lymphoid neoplasms, but sometimes they're not easily possible to be done clinically. So the clinical diagnosis usually rests on the pathologist trying to diagnose based on the morphological appearance and the antigen expression on those malignant cells. And then in addition, we will have some clinical features that would also suggest towards this diagnosis. Say, for example, as I hinted before, there is a preponderance for skin lesions to be present, blood and bone marrow involvement to be present. So those are also factors that give us a clue that this could very likely be a BPDCN type of presentation. And then there are more and more additional studies that are coming up to give us some understanding about what are all the underlying genetic changes that are seen in these malignant cells, so that we can try to understand how they affect the prognosis and in what way they could influence the treatment in terms of choices, responses, other potential new treatments based upon options that are available through new agents.
So, how do these patients present?
Yeah, so majority of the times whenever we see these patients, skin lesions are one of the very classical presentations. So they present with some new skin nodules, plaques, or bruise type of lesions that are seen in the skin. With other acute leukemias and other aggressive malignancies, we do commonly see symptoms like fatigue, fevers, night sweats, shortness of breath, weight loss. This is one of the myeloid condition where we do tend to see some lymphadenopathy, because usually when we see lymphadenopathy, we tend to think it's most likely a lymphoid malignancy. But this is because of this preponderance for malignant cell infiltration, we can see lymphadenopathy in this condition. Same way, just like how we see with some of the myeloproliferative disorders, splenomegaly can be one of the manifestations when it comes to BPDCN. Because of how aggressive the disease is, if the growth is more fast, patients sometimes present with pains, particularly bony pains. So those are also aspects that can be seen in clinical presentation. And because these patients do tend to be immunocompromised because of the malignant proportion of cells that are affecting their immune system as well, they do tend to be at risk for infection. So presentation with infection symptoms is also a possibility.
So, how do you diagnose it?
Yeah, that's the biggest part, I would say. To actually first get to a best treatment, we need to have that diagnosis established correctly. And to have the diagnosis established correctly, we need to first be thinking about this as a possibility. So I would say anytime whenever we think about a new patient who has blasts that are detectable either in the blood or in the skin lesions, particularly if they present with skin lesions and we think that may be AML, the first thing we try to think about is it BPDCN or not? Because unless we look into certain markers, we wouldn't be able to establish the diagnosis. So the pathologist, a trained pathologist, would be able to tell us if they're seeing plasmacytoid dendritic cells that are represented in the biopsy predominantly. And then if they are finding it, they do immunostaining, particularly for the four antigens that we talked about previously, such as the CD4, CD56, CD123, and then TCL1. And then flow is going to be very key in terms of helping us establish this concrete diagnosis. And then additionally, we also check for cytogenetic abnormalities to see if they have any chromosomes that are abnormal or normal. We do tend to perform other additional studies like next generation sequencing to identify what mutations might be present that might be contributing to this condition in terms of progression, in terms of additional treatment options and things like that. And in addition, we also try to do a general assessment for a newly diagnosed patient, similar to what we do for other malignancies. Say, for example, checking their complete hematological parameters, their liver functions, renal functions, assessment for other areas of extramedullary disease using CT scans or other forms of imaging to first make the diagnosis, identify the burden of involvement, so that we can try to plan for treatment accordingly.
Yes, some physicians have commented on the mnemonic for the CD 1, 2, 3, 4, 5, 6, CD 123, CD 4, and CD 56. That's
Exactly
I
that.
guess an easy way to remember it.
It is. It is. We tell the fellows always that remember that 1, 2, 3, 4, 5, 6. 1, 2, 3 is the first one, 4 is the second one, and then 5, 6 is the third one. If you remember this, you'll definitely get a BPDCN diagnosis.
Great. So obviously, this is an area where treatment options are starting to expand. So how do you approach a patient with BPDCN today in your clinic who's newly diagnosed?
Absolutely. The treatment options are definitely much more expanded at this point of time in the last few years, particularly, I would say. Because previously, when we used to treat BPDCN, the main approach that we had is treat them like an acute leukemia, either it's a AML or ALL, with the intensive chemotherapy if a patient can tolerate that. So that used to be the primary treatment in terms of cytotoxic chemotherapy for newly diagnosed BPDCN patients a few years ago. In 2019, we had clinical trial data presented on a very exciting drug called tagraxofusp, which is actually a drug that targets CD123, an antigen that is very well expressed in BPDCN. That the study was published in the New England Journal of Medicine. Basically, the tagraxofusp is a drug. It's a targeted drug that targets CD123 that is well expressed in BPDCN. It's given as a single agent. It was studied in a limited number of patients on a clinical trial at two different doses. The responses were really good. And then majority of the patients who achieved a response were even able to go to stem cell transplantation, which is considered as one of the consolidative and a potentially curative therapy for patients when they achieve a remission in BPDCN. So at this point of time, the first line approach that I would be thinking about whenever we see BPDCN is actually consider a targeted therapy such as tagraxofusp. We also consider chemotherapy in situations where either we cannot have a targeted agent, or say, for example, there are other indications to basically say we need to get chemotherapy to get the disease burden controlled soon enough. And then subsequently, once patients are in remission, we start looking towards potentially doing allogeneic stem cell transplantation. Again, these are current standard of care options, but with this being a rare condition, very limited number of new drugs being available, this is one condition where I would definitely say prioritizing a clinical trial, if it is available, would be a very, very important option. And that would be the best way that we can try to develop more and more new therapies, more and more effective therapies, so that we can get it out to many patients as much as possible. There are some patients for whom the involvement could be very limited, say, for example, isolated skin lesions or isolated areas in the body without widespread involvement. In those situations, we consider radiation therapy. In some situations, even if they have widespread disease, but disproportionately affecting one area where there is less effect on the targeted therapy or the chemotherapy, we do try to add radiation therapy to the other additional treatments as well. So targeted treatment, radiation therapy, chemotherapy, stem cell transplantation, these are going to be the most important big ways of looking into the treatment. And the most important one, as I highlighted too, is actually looking into clinical trials.
So what are the challenges you face today in the management of your BPDCN patients?
I think most importantly, getting to the diagnosis. There are many patients that sometimes I see who have been having a difficult time getting a diagnosis established, maybe because they're seen at centers where there is not much awareness or not much ability to diagnose this condition correctly. So that itself leads to a delay in diagnosis, and sometimes that could compromise the ability for a patient to receive the right treatment at the right time. So I think getting the diagnosis established is the number one important part. I would say is the biggest challenge, and it's easy. It's an easy fix. If it is a difficult part to diagnose in a center which hasn't seen that many number of patients, the easiest way is actually to be in touch with a center which has seen a better number of patients, a referral center in the corresponding area, and then try to discuss with them or potentially have them be involved to establish the diagnosis correctly. So that's number one. Number two, we have come a long way from just being reliant on cytotoxic chemotherapy alone to more and more targeted therapy at this point of time. But we don't have too many targeted therapies option. We only have one targeted therapy option at this point of time. And even at this point of time, we don't have a randomized study that has compared targeted therapy and chemotherapy. So we don't have a good standard of care that is established. So I think there are challenges to complicate all these things. It's a rare diagnosis. We don't have that many patients that are diagnosed overall with this condition. So to actually advance the science, do effective treatment for patients, there is a lot of need for more research to be done through clinical trials and other aspects in this condition. And then in addition to that, the treatments that are currently available, unfortunately, is not able to cure every patient. We do still see a high number of relapses after patients achieve remission. And then when patients relapse, sometimes the options are even much more limited when it comes to treatment. So there is a high need for more and more newer treatments and novel agents in this area.
So can you give us a little idea of where this field may be going in the years to come?
Absolutely. So I think we are at a point where the molecular mutations are really helpful, not just to understand the disease's natural history, but also helpful to identify targeted treatment. So using some of the genetic abnormalities and the antigens that are expressed in BPDCN, there is more and more research looking into new treatments that target the BPDCN cells, particularly either through the antigens expressed or through the molecular mutations, so that it could try to target the BPDCN cancer killing more effectively. This is also an era where immunotherapy has become a big important part in multiple conditions, such as bispecific antibodies, CAR T cell therapies. All those things are also being looked into from BPDCN management perspective. Stem cell transplantation has always remained as an important treatment option for these patients, but there are more and more new ways to minimize the transplant related toxicity, improve the efficacy of the transplant, and make it a better option and a potentially highly curative treatment options for many of the patients, particularly with more new donor sources that are being available. Um, Whenever we have two different groups of drugs, targeted drugs and chemotherapy, there are also efforts to combine them in a safe way to basically see if that can be more effective in treating the cancer without causing too much toxicity. So there are also research that are being done to actually integrate chemotherapeutic agents, particularly the novel chemotherapeutic agents and targeted agents. And then more and more research to basically identify new biomarkers, which can basically predict treatment responses and also which can be able to help understand what would be the natural history of BPDCN based on some of the biomarkers that are expressed. And then because it's a rare condition, not that many patients are seen, there is more and more effort to build prospective registries, retrospective registries to capture these patient information in a de-identified way so that we can try to have that as a reference point so that in future more and more patients, if they do get diagnosed, they can be captured all on those registries so that new treatments can be basically developed through some of the information that are gathered through them. So multi-pronged approach here. All of them hopefully will be able to effectively lead to good treatments in this condition.
So, one hears more about this entity than one used to in the past. Is that just because of increasing recognition, or what? Because I think that years ago when I was in training, we hardly heard about BPDCN. And as you said, now larger centers see often more than a couple in a year. So, um, what is the reason for that?
I think the important part is we are more clear at defining the problem currently, particularly credits to the classification system such as the WHO, which has identified this as a unique entity so that we are all aware of it. Secondly, whenever we have a disease, when we have a new treatment that works, that makes the disease more and more prominent as well. Say, for example, with that first targeted therapy that's available for BPDCN, people are more and more aware that this is a treatment that can be given to a patient if they are able to actually receive it and be diagnosed in the right way. So I think the combination of identifying the problem, trying to also say that there is a potential solution for the problem, has made it more and more familiar to the hematological disease experts and physicians at this point of time, and also to patients as well, so that they are all aware of this as a condition that needs to be kept in mind whenever we are seeing symptoms or presentations that could be a part of this condition.
And my last question, what is the prognosis of a patient with BPDCN diagnosed today? What can they expect?
At this point of time, there is still a lot of room for improvement. Most of the registry studies and others have unfortunately showed the median overall survival is still low. But more and more clinical trials are actually showing encouraging efficacy. For example, the clinical trial where BPDCN patients were enrolled, more than half of the patients were actually alive at more than a year and a half to 2 years, which is a reasonably good number compared to historically what we have seen with this disease condition. So I think there is more room for improvement, and there is definitely more and more hopes that we would likely have improvement over time. And we are looking into, from a research perspective as well, to historically compare the data over time and see how much improvement we are making. And I'm hopeful that in future we'll have more improvement with more availability of new drugs as well.
So is this curable for some?
For some patients, yes. I think if we are able to get them to remission and then subsequently get them to an allogenic stem cell transplantation, we have seen patients who have had long-term remissions and potentially comfortable saying that they are cured.
Well, I really appreciate your taking the time today to talk to us about this rare entity, but also one with increasing recognition, as we said. And I hope that I can reach out to you for a discussion on another topic in the future.
Appreciate it. My pleasure. And it was very great discussing about this topic, and appreciate all the work you do.
Thank you very much.